Good morning, and thank you for watching Eye on New Mexico today. My guests today are here to talk about a very important issue. We'll be talking about mental illness, mental health treatment, and mental health policy here in New Mexico. My first guest, Brian Stetton, is the policy director for the Treatment Advocacy Center, which is a nationwide group. Thanks for being here in New Mexico.
Thanks so much for having me.
Brian, yes. And Dr. Albert Dugan, who is with the National Alliance on Mental Illness. We know you guys as NAMI here, and he has also had some personal experiences dealing with a family member suffering from mental illness, and we'll talk to him about that. Thank you for being here, Dr. Dugan. Well, Brian was here in Albuquerque recently to talk about New York's Kendra's Law, as it's known in New York. This is assisted outpatient treatment, which a number of states, including New Mexico, are looking to enact to deal with some high-profile mental illness cases. Now, some background on Kendra's Law. It was named for this woman, Kendra Webdale, who was pushed in front of a New York subway train in 1999 by a mentally ill person who was not receiving any treatment at the time. The law, basically, my understanding is that it gives judges authority to order certain mentally ill patients to undergo psychiatric treatment. And it is a controversial law, but Brian can tell us more about it. He was the policy aide to former New York Governor Elliott, or New York Governor Elliott, Attorney General Eliot Spitzer, where you drafted the original proposal of Kendra's Law there in New York. Is that right?
That's correct.
Tell us about that, what Kendra's Law in New York is, and what you're doing here in New Mexico as we try to, as a lawmaker here tries to propose a version of assisted outpatient treatment.
Sure. Well, as you say, Kendra's Law came about in New York through a tragedy. A young woman from upstate New York who was down in New York City pursuing her dreams was pushed in front of a subway train by a young man who was very much known as a ticking time bomb by people who had dealt with him in the mental health system. Not a lot of people who had had interactions with him through giving him care were shocked by what had happened, unfortunately. And it raised a lot of questions in New York. Well, why is it that individuals who are in this condition, who are so gravely ill and untreated, are in the community and unmonitored? And what we found in looking at New York law at that time is basically there were two states that a person in this condition could be in at any particular time. Either the person was found to be dangerous to themselves or others at that moment, in which case they were hospitalized. But as soon as that individual became stabilized and responded well to the medication, they were released from the hospital and free to make their own decisions about their treatment, however poor those decisions might be. A large part of the problem we learned as we looked into this is that many individuals with severe mental illness, as part of that illness, don't understand that they're sick. They have a condition called anosognosia, which makes it impossible for them to know that they even have an illness that requires treatment. And so when you put yourself in someone like that's shoes, it's not surprising that people often don't take their medication. And I should stress, this is really a subset of people with severe mental illness we're talking about. Most people with mental illness don't have that particular problem. But for those that do, it's highly predictable that all kinds of tragedies will result. And so the law that we created out of that, we created a system where throughout the state, counties were required to establish programs that would allow judges to order individuals who had this particular history of not only having severe mental illness, but not taking their medication and having disastrous consequences as a result of that. Ordering those individuals to comply with a specific treatment plan as a condition of remaining in the community. And it's a form of commitment.
One perception that some people have, and I don't know if this is correct, does Kendra's Law or do other states with an assisted outpatient treatment law, does it allow a judge to force someone to take medication?
It allows a judge to order someone to take medication, but one of the misunderstandings about this and why it's often mislabeled as forced treatment is that it does not actually allow the person to be forcibly medicated, that is, held down and administer drugs that they don't want to take. That's something that can only take place in a hospital environment, and appropriately so.
This law, Kendra's Law in New York and under other names in other states, what is New Mexico trying to do right now? Because we know Albuquerque had a similar version of this on the books that was struck down by a judge as being inconsistent, conflicting with state law here. And it's come up in our state legislature in the past, but now our state senator Mary Kay Papin is proposing another version of this. Is it different than other laws? What is your role in crafting this and talking to our state lawmakers here?
Yeah, well, I've been helpful, I hope, in working with the aides to the legislature in crafting the specifics of the proposal. But I would actually say what's been proposed is much more like how AOT, assisted outpatient treatment, exists in just about every state other than New York than it is similar to New York's law. The thing that's unique and unusual about New York is that it requires that every county have one of these programs. It's actually a statewide mandate that says everyone shall do this. The way this works in most states is this is something that is on the books. It's a tool to be used by local mental health systems who see the value of it and want to use it. It's also something that they could not use if they feel they don't have the resources to make it work. And so what has been proposed this year in New Mexico is something more like that. And we're talking about, at this point, 45 states that have laws of this type. There's only 5 left that don't. New Mexico's on a very short list at this point. But this would create a tool that communities such as Albuquerque could use to establish programs like this. But would not mandate that they do so the way New York does.
Now that's interesting. So what you mean by they could use it is that they would be under their legal authority then to have a judge author or order mental health treatment for a patient?
That's right. And you know, as you mentioned, Albuquerque tried to do this on its own after the frustration of not being able to get a state law passed in the early 2000s. In 2006, Albuquerque tried to create their own city ordinance that would allow them to create one of these type programs. And the judge said, until there's a state law that authorizes this, you can't do it.
I see.
And so this would now give Albuquerque and whatever other cities or private hospitals or counties within the state that want to create programs like this, the green light to do it.
Albuquerque's law in 2006, the effort there was much in response to a case we had involving a man named John Hyde, who went on a killing spree, killing 3 civilians, 2 police officers as well in one day. And the fact that he had been in and out of mental hospitals, was off his medication. So this law sometimes seems to come up in response to a very high-profile case, as we saw there in New York, for example. Does it really apply to a majority or a large number of mentally ill individuals, and therefore does it work? Does it have an effect?
Well, thank you for asking that, because it's a really important clarification we need to have out there. The great majority of people with severe mental illness are not violent. Are not likely to commit these kinds of incidents that everyone hears about. And I certainly understand the concern of some that we're perpetuating stigma by drawing attention to these incidents. The problem is that there is a subset, a small subset, within the group of folks that have mental illness in general, who, for the reasons we've already discussed, have trouble adhering to their medication. And so when you look at individuals who are unmedicated for these very severe mental illnesses, which is, again, a small subset, when you drill down to that group, the statistics and the findings are really quite different. That is a group that is at high risk of committing violent acts. But, you know, even much more typically, among that group, the kind of personal disaster, the very sad stories that we see are not the kinds of things that make the papers. It's people being homeless. It's people burning bridges with their families. It's people committing all kinds of petty crimes that have them, sitting in jail cells when they should be getting treatment. And so these laws help individuals who are unmedicated and unable to take control of their own need to be medicated. And that's going to include some people who will commit acts of violence and lots of people who won't. But the most important point is that it's not going to affect most people with mental illness at all.
In the experiences that other states have seen in New York and others with laws like this, do family members often get involved? Are they some of the people calling for the patient to be forcibly treated? Absolutely, because the family members are the ones living this horror more than anyone. I mean, they're the individuals who who are getting, to deal with the brunt of this problem when people are released from hospitals and sent back into the community. The families have a choice. I'm either going to take this person in and live with this unlivable situation in my own home, or, very often what happens is they just can't deal with it anymore, and people wind up homeless, and, families are in heartbreak over it. Dr. Albert Dugan, we introduced him earlier, has a personal experience with this. Doctor, tell us about your family experience.
Mine experience only is slightly different in that the health of this person deteriorated enough so that they did get into the criminal justice system. Had some time in a forensic medical unit for people with judicial questions, but was released and then managed under outpatient treatment and management since then. So it was under a different law perhaps, but still got treatment that we were unable to obtain for this individual, by and it was a nonviolent crime and so forth, but nonetheless got the person into the medical system, got evaluated, and then the court did order the treatment. And so that was suspended after a while, but still the family member chooses to take the medicine and is doing much better now.
Did it take a criminal action to get to that point, though? It sounds like this person had these issues, obviously, leading up to that. Was it a struggle to get them treatment? Yes,
certainly a struggle to get them into treatment. And then, in this case, the person was so upset, they were near a squad car trying to find a disguise, is what is said anyways. And the officer interpreted that he was trying to get in to get a gun out of the vehicle, and so he was arrested on that basis. You know, so it's a little technical, but still, the idea was that before that we couldn't get anything done. You know.
It must be such a struggle for family members. Now, NAMI, the National Alliance for Mental Illness, of which you're a member, supports the idea of outpatient-assisted treatment. But in your personal experience, do a lot of families support this idea?
Yes, just as you would if you saw a skin spot that looked dark and you should go to the doctor and check on it. You're seeing all these behaviors and symptoms that are quite different from the person you know and love, and they don't have an insight into that there's a problem, would deny it, and so you would try to persuade them to go for care, and they won't go. And if you go to the emergency room and they don't seem to be a big threat to the community at this time or themselves, then the emergency room is going to send them out. There's often no beds, and a person who's not motivated to have treatment anyways. Why do I waste a bed on a person who doesn't want to cooperate with treatment? You know, so they get sent out.
You know, you bring up a good point there, though, and that is that it still requires some level of cooperation from the patient. And what if they just don't want to cooperate? I know that some of the criticism of these kinds of laws are that it makes patients less likely to want to cooperate. They feel like they're being attacked. Is that accurate?
Well, it's not at all accurate, and I think you know the results really speak for themselves here. This is a practice that has been around for a while, decades, and has been studied in a number of jurisdictions, and the results just don't bear out those fears at all. In fact, what we find is that people do a whole lot better. They're much more likely to adhere to their treatment. The rates of hospitalization plummet, rates of incarceration, suicide, just about any harmful behavior that we're trying to avoid goes way down when people are in these programs. And it's largely attributable to something we call the black robe effect. It's not that there is a whole lot of teeth in these laws. We're not talking about, you know, draconian consequences when people violate these orders. As we said, it can't lead to forced medication. But there is something about being told by a judge, this is something that we expect of you, the ritual of going through that court process, that has a profound impact on people, and this is borne out again and again by studies. Another interesting finding is that, you know, there's so much concern about people feeling stigmatized and this being some kind of scarlet letter that's going to drive people underground. But, you know, in one New York study, they asked people who were under AOT whether they felt stigmatized or coerced into treatment, and they compared their responses to people in the mental health system who were not under these court orders, and found no greater likelihood of those feelings among people under AOT. What seemed to predict whether people felt stigmatized or coerced into treatment is how respectfully they felt they were treated by the individuals who provided care to them through the mental health system. And there's absolutely nothing about AOT that prevents treating an individual with respect and dignity. And that's what it's all about.
We will continue our discussion and talk a little bit more about mental health resources here in New Mexico with Brian Stetton and Dr. Albert Dugan. Stay with us. We'll be back in just a moment. Thank you for staying with us for Eye on New Mexico. Once again, my guest today, Brian Stetton from the Treatment Advocacy Center, the policy director there, and Dr. Albert Dugan from the National Alliance on Mental Illness. Thank you both for being here to talk about this very serious issue, of course, here in New Mexico and nationwide. And before the break, we were talking a little bit about assisted outpatient treatment, known as Kendra's Law in New York, where Brian helped create that law, and New Mexico's efforts to get a law like that on the books. I wanted to also talk about, just in general, the resources available for mentally ill people here in New Mexico. And Dr. Dugan, we were talking with you about having a family member that suffered from mental illness. Last year, of course, many of us know that the state effectively shut down 15 behavioral health centers in New Mexico as part of an audit looking into some fraud and Medicaid overbilling. But it really left patients as the victims there because people just didn't have these services available to them anymore. Even before that, were there enough resources for mentally ill people?
No, nationally we're resource poor in behavioral health, but certainly in New Mexico, medical care in general is a little more scarce, and certainly in behavioral health it is. And then the problem last year with those providers being terminated, it has an immediate effect on availability of services, but it also has a chilling effect on any kind of recruitment or retention. People who are working here may look at another state and decide maybe I'll go to a place that's a little friendlier to behavioral health providers. And if I'm a doctor trying to get a partner to come here, I have a hard time. If I run a business and I'm trying to bring somebody, an executive to this town, and you make headlines with termination of health care, behavioral health care, you already have discussions of educational quality in the state. None of those things help us recruit new providers and improve services. And I think we even had a setback in reduction in availability of care over the last year.
Certainly it is tough, as you mentioned, to get doctors here focused on that. And you know, having a family member dealing with this issue, we've talked a lot about mental illness in light of Albuquerque police, the jail, for example, being overcrowded with mentally ill patients, the homeless population. So this really sort of becomes involved in almost every news story we report on here, and so many of the news stories we report on. As someone who's had a personal experience with it, how do you think the mentally ill are in general treated in society?
Once one gets into a provider, I think their experiences are pretty satisfactory, you know, and we probably, if you have somebody in behavioral health in New Mexico, they're pretty dedicated to it, or they wouldn't be here. And so we think the providers we have are doing good jobs on individual reports, good care. But getting access, I know of another friend from my church who has not been doing well lately and wanted to be seen at the university, and that appointment will be sometime off in the fall, and that perhaps is okay for my regular physical, but if I'm really in distress with my mental illness right now, I don't want to be told November or something is my appointment. You know?
And in general, the stigma surrounding that idea of mental illness that seems to affect just the way that people are seen on the streets, that people are dealt with by the police, by jail officials, by other community members. Is that a problem? Right.
I mean, maybe odd behaviors, just living homeless, which I think the mayor has made a serious effort to reduce the homelessness. We know if you have housing, that's almost more important than treatment. If we give you a shelter, you get a meal, then the medications, the doctor visits, other things begin to fit into your life a little better. If you're just looking for a place under the bridge to stay tonight, everything else seems out of reach. You're not going to have a solution. So handling that has been important. And then I think the shelter is the main thing, the first step, and we're working on that.
But that's a great point, that network has to be there of social services already in place for some of those other issues that mentally ill people deal with. Bringing Brian back into the discussion here, part of something that people may not understand about assisted outpatient treatment, Kendra's Law in New York, is the idea that you're basically targeting every person with a mental illness to get them into the system, to get them taking medication or undergoing treatment, when really this is more of a treatment plan once people are hospitalized or brought into the system for some reason. Is that right?
Yeah, that's absolutely right. These are not individuals who the system does not know about. These are those who qualify for this, those who will meet the criteria under the law to even be eligible for one of these court orders, are going to have had lots of contacts with the mental health and or criminal justice systems as a result of their inability to adhere to their prescribed treatment. And so the way this is typically used is that a person coming out of a hospitalization at the point where they are stable enough to go back into the community, they no longer meet the inpatient criteria, they will be given one of these orders as part of their discharge planning, so that they will have a sort of a soft landing back into the community and aren't just going to be completely left to their own devices and left to figure things out on their own once they get back into the community. So that's really the optimum time to put one of these court orders in place.
We talked a little bit about in the first segment statistics that have shown the success of these types of laws.
Right.
You know, when we actually look at what people see on the news, the violence that sometimes is perpetrated by mentally ill people, that, I mean, we hear about laws like Kendra's Law when we hear about a terrible tragedy like Kendra,
right.
Who it was named for,
right.
or John Hyde here in Albuquerque, and those types of stories.
Sure.
So, when you're sending someone back out into the community, tell us about some of those statistics. Are you seeing less violence in New York, for example? What are the real hard facts of what's happened?
Yeah, absolutely. I mean, the studies that were done in New York and elsewhere have shown that it does have a real impact on a likelihood of violence. There was one study that was done at the School of Public Health at Columbia University where they compared folks under AOT to a control group of patients who didn't quite meet the criteria for AOT, who actually had less violent histories in the AOT group. And they found that at the end of this intensive treatment period, that there was actually a 1/4 the risk of violence among the group who had been under AOT, and that was a group who had been more violent to begin with. So, you know, I really hate to sell this primarily as a violence prevention measure, because most of the people who are going to be helped by this are not at risk of committing serious acts of violence. But, you know, I also think we're putting our heads in the sand if we ignore that that is one of the issues that untreated mental illness leads to, and that can be helped by having these kinds of programs.
That's a great point, and it kind of gets into this other question of how many people end up in this type of treatment program, outpatient assisted treatment. In New York, you know the numbers there, right? Yeah,
well, it's been in a state of 17 million people. There's been about 10,000 people who've been put under court order in the 15 years of its existence. So, you know, that gives you an idea of just how small a number we're talking about. There's, you know, less than 1,000 people at any given time in a state of 17 million who are under these orders. So if you extrapolate those numbers to the population of New Mexico, I think, you know, it sort of hits home that we are talking about a very small subset of people with mental illness.
Dr. Dugan, the hope, of course, is that enacting a law like this would get some people into a treatment plan that they will follow, that will help improve their lives, families' lives, all around. But clearly, this can't be the only thing that solves the problem of mental illness in society. And what else is NAMI pushing for? Tell us about that.
Well, treatment is the first 3 or 4 points, certainly, you know. And obviously reducing stigma, advocacy for protecting benefits that are provided, the Medicaid expansion, again, accesses people to treatment and to services, and we've benefited from that in New Mexico, where we're able to enroll, and we even hope it will expand the number of people who have full services in New Mexico with that improvement. I would just say, in terms of the liberty question, or should we talk about violence, often this business of not having a treatment program enforced is that if you're under a bridge on a mattress lying in your own waste, you're not free. If you're standing on the overpass asking for food or housing or help, those are the people that we think benefit. And repeatedly, when they get into treatment, they thank us for getting them to services, getting them to someone who does understand them and talks to them and appreciates them. And maybe they haven't had any support in their own home, and they realize that for the first time. So there are great benefits. And so I think that still getting access and getting them in the door is most important.
Are there other laws that need to be enacted then to create that, to open the door for that? Not just outpatient assistant treatment, not just types of laws like Kendra's Law that will allow a judge to order treatment, but you know, what else can a lawmaker do, basically, is the question.
Yeah, there's no question. A large part of the problem that you have in New Mexico and in other states, just about all states, is resources.
Yeah.
So it's something that really has to be looked at budget time. Right, there have to be resources put into the mental health system so that these programs exist that we can even ask people to be complying with under an AOT order. You know, you can't ask a person to adhere to services that don't exist. So there's no question that is a huge part of solving this problem. And AOT itself is not a magic bullet. It doesn't solve that particular problem. But you know, at the same time, it recognizes that even if you have the greatest availability of services imaginable, people who don't understand that they're ill, who don't think they have any need for those services, aren't going to avail themselves of them. So it really is both things that have to happen.
Absolutely. And before we run out of time here, Dr. Dugan, any message for family members dealing with this who may be watching? Is there a first step they can take, something they can do right now in hopes of moving in the right direction?
Right. They can contact the NAMI organization in Albuquerque or in their cities. There's chapters in Santa Fe and Las Cruces and elsewhere in the state. The DBSA organization support group for depression and bipolar people have support groups for family and for their members, and there are other support agencies. Probably the idea of community support, whether it's with your church, maybe developing it in your own congregation, is helpful. And sometimes I can't help my family member, but I depend on someone else to do that, and maybe I can in turn help somebody else that I know is having problems, so that sometimes we're the least able to help our own family, as perhaps in many family situations, not just in behavioral health. So just knowing that you're not alone and building these networks and supporting each other, community care is important.
That's a great point, and everyone with a family member in that situation would want others to help if they can. So thank you both, Brian Stetton from the Treatment Advocacy Center and Dr. Albert Dugan from the NAMI, National Alliance on Mental Illness. Thank you both for being here today to talk about this issue, and we will see you next weekend for another Eye on New Mexico.